Hello and welcome to the continued NMC education series. The topic for discussion today is difficult to manage constipation, anorectal malformation and Hirschsprung's disease. To discuss with this, today we have Professor Jason Frischer, Division Director of the Colorectal Services at Cincinnati Children's Hospital and Consultant Colorectal Surgeon at NMC Royal Hospital, Khalifa City. Welcome, Professor. It is nice to have you on our show today.
It is an absolute pleasure to be here.
Professor, we often see following Hirschsprung repair, many children have difficult constipation and soiling. My question is, why do they get it and how do we manage them?
First, thank you very much for the question and allowing me to be here. Hirschsprung's disease is a chronic condition. Many people believe that after the initial pull-through surgery, everything is done and taken care of. That is actually not true. Over half of the patients that have an excellent repair and surgery for the diagnosis of Hirschsprung's disease continue to have problems during their infancy, childhood ages, and beyond. And so having a dedicated team approach to taking care of this patient is very important. So when I get asked to see a patient with Hirschsprung's disease and having issues after their surgery, you have to have a really organized approach. And the way I do this is I start by having every patient have a contrast enema, so I get a roadmap of the colon and see what the anatomy looks like from this radiologic study. And then I always take that patient to the operating room for a rectal exam under anesthesia and potentially a rectal biopsy. When we go to the operating room, there are some key things I'm looking for. One, I do an external exam. Does the anus look patulous or were the muscles stretched? Then I look at the anatomy. I look to see, is the anal canal intact? Did the surgery damage the dentate line or the anal canal? If it did, that would cause a great increase in fecal incontinence. Then I look to see, is there a problem with the anastomosis or the connection of the pull-through? Is there a stricture? So I use Hagar dilators to size the patient to the proper size to make sure there is no stricture. I do a digital exam to see, is there a fecal impaction? Normally you could see that on a contrast enema, and if you see that, be prepared in the operating room to perform a fecal disimpaction. Then I pass a 24 French Foley catheter to test to see if there's a twist or turn or kink in the bowel that happened during the pull-through procedure, because that could happen and cause problems with post-operative care. Finally, I take a rectal biopsy. There are many times where patients have normal pathology at the time of their original pull-through procedure, but following the pull-through procedure, they have problems, and then there is that chance of having transition zone bowel pulled through or aganglionic bowel pulled through, and that would require further surgical intervention. So having that initial workup, I think, is very important because it's really key to know the anatomy and know how the surgery was performed and the outcome of that surgery to help treat that patient that's having problems later after having their original pull-through procedure. If the pull-through procedure, you don't find any issues on the rectal exam or the contrast enema, or even if you do, then the next step is to see them in the office, and we like to do something called bowel management. I'll go into bowel management in much more detail in its different segment, but the keys are a program dedicated to evacuating the bowel in a consistent manner. This could then either make the patient fecally continent, or sometimes we need to do enemas to make them socially continent. What does that mean, socially continent? We mechanically empty the bowel so that the bowel is free of stool for 23 hours, and during the 1 hour of bowel management every day, you're evacuating the stool so that your child could be clean and in normal underwear.
What is this bowel management program all about? What do we expect children to achieve at the end of this program?
Bowel management is an organized, coordinated team effort to try to help children who either suffer from constipation or fecal incontinence, whether it be idiopathic or for reasons unknown, or because of congenital conditions such as Hirschsprung's disease or anorectal malformation. It starts with an education of what bowel management is for the patient and the family. Then we have an office visit, usually in combination with a gastroenterologist and a surgeon, to discuss the patient's signs and symptoms, get a good physical exam, and then come up with a coordinated plan. Bowel management can be divided into two separate arms: patients who need enemas and patients who could use laxatives. We decide that in combination with the family and based on the situation for that child. When children have something called true fecal incontinence, a situation or condition where we know the child cannot be continent, then we go to the enema program. In patients who have something called pseudo-incontinence, then we use a laxative program. Of course, depending on every situation, one patient may not fit exactly into one category or the other, and that's why we have individual appointments and meetings so that we can discuss the care of that child. There are some very important keys to bowel management, and I'm going to go over them now. The first key is that we start every patient with a good history and physical, and we decide, is that patient able to be continent of stool? How do we know? Well, if they have a congenital malformation or congenital issues that may be more apt to have fecal incontinence, then they may be truly fecal incontinent. Patients often that suffer from conditions that just cause constipation have what we call pseudo-incontinence. The child backs up with stool, they're actually constipated, but the loose stool leaks around the hard stool and causes leakage or soiling or diarrhea. So many families think their child has diarrhea, but in actuality, they're constipated and have what we call overflow incontinence. The loose stool leaks around the hard stool and causes problems. We have to address that. We start by doing something called a contrast enema. We use a dye in the radiology department, inject the dye in the rectum, and investigate the entire colon. This study does two things for us. First, it gives us an anatomic roadmap of the colon. We can see if there are any anatomic problems, twists, turns, kinks, extra intestine. Anything that we could see could be detected by this study. But second, the dye we use is water soluble. It brings water into the colon, which loosens up the stool and helps us evacuate the stool during the initial parts of bowel management. Once we determine the contrast study and its findings, then we decide if we go into the enema or laxative program. If we do the enema program, the program consists of making sure that the colon is completely empty. This is a very key component to bowel management. Before starting the bowel management program, or in the initial phases of the bowel management program, it is super important to make sure the colon is empty. And in my opinion, the only way to tell that the colon is completely empty is to get an X-ray and demonstrate this. Physical exam is not sensitive enough to determine if the colon is completely empty. If the colon is completely backed up with stool and you start using oral agents for laxative management or enemas by rectum, it will not work. It will either cause nausea and vomiting with the oral agents or incomplete enema administration given rectally because of the fecal impaction. So you must empty the colon out first, whether that is with medications, enemas, going to the operating room and doing a manual disimpaction, or all of the above. That is the key step in bowel management. Once you have that clean colon, then you devise a maintenance program. And we, for the enema program, use a daily large volume enema combined with an irritant. We typically use normal saline and either glycerin or soap or a combination of those to help empty the colon. That is administered every day. It usually is administered over 10 to 15 minutes. And then the child sits on the potty for about 45 minutes to evacuate. The expectation at the end of this program is that the child completely empties the colon during that 45 minutes to 1 hour period, and the other 23 hours of the day, they are not concerned with their bowels. The bowels should be clean. This is what we call socially continent. We mechanically empty the colon so that the bowels could be clean and the child could be in normal underwear, running around, playing with their friends, and being no different than any of their colleagues. Now, if a patient is deemed to have the ability to have control or be continent, then we use laxatives. The ability to have control or be continent means that they have the muscles, the nerves, and the motility of the colon to be clean of stool and evacuate the stool. If we deem that the case, then we use typically stimulant laxatives to empty the colon. There are only really 2 stimulant laxatives that we know in the market today. One is Senna and the other is bisacodyl. All other medications that use the term laxatives are osmotic laxatives, meaning they bring fluid into the colon to loosen the stool, but it does not cause stimulation. So when I talk about stimulant laxatives, I'm talking about a medication that makes the colon squeeze to help propel the stool out of the colon. We use a trial and error method using the stimulant laxatives to determine the right dose of laxative for each child. 2 key components when doing this trial. The first is to make sure the child stools every day. We typically like the children to have 1 to 3 good bowel movements a day, but that's not enough. We also need confirmation that the colon is actually emptying, and we do that with an X-ray. The only way to really know if the colon is emptying and evacuating is with an abdominal X-ray. It is very hard to judge if a child is completely evacuating or moving the stool out of their colon without imaging to confirm this. So in conclusion, bowel management is a coordinated team approach in helping empty a child's bowel and giving them a regular bowel movement every day. Some patients need the enema program, some patients need the laxatives program, and some patients are able to do one program for a period of time and then switch to the other program. It all depends on your child and each individual situation. Our bowel management program was originally designed for patients with anorectal malformations and Hirschsprung's disease. But due to the great success we had with this program at Cincinnati Children's Hospital, we started to see an influx of a number of different patients with different conditions coming to see us. Actually, a huge number of our patients now have just constipation or fecal incontinence or a combination for a variety of reasons. And we have seen the same outcomes with these conditions as with the original surgical conditions when we started the program. We have brought our bowel management program to NMC Royal Hospital in conjunction with Dr. Dinesh. We have been here for over 2 years and have seen well over 100 patients. And I'm excited to say that our outcomes here in Abu Dhabi are the same as our outcomes in Cincinnati. It has been a great partnership, and the best part about this is that we're giving great care to the children of Abu Dhabi and the surrounding regions.
What are the new innovations that are available for the treatment of constipation and fecal incontinence for the families?
Some very exciting and new innovations have come out for the treatment of constipation and soiling. I think the biggest thing to hit the market in the last few years is something called sacral nerve stimulation. Neuromodulation treatments throughout the body are becoming extremely popular during the last few years. Recently, we have started treating patients in Cincinnati Children's Hospital with something called interstim or sacral nerve stimulation. It is a way for patients to have a pacemaker-like device placed on the third sacral nerve, which is the nerve that controls the bowel and urinary tracts. And with this stimulation, we can see better outcomes in certain populations. Let me take a step back. We don't know exactly which patients are successful with sacral nerve stimulation. But in our bowel management program, when patients reach difficult times, one of the options now available is something called sacral nerve stimulation. It is a 2-staged, minimally invasive procedure in where we place an electrical lead on the third sacral nerve and connect it to a temporary device for which we see if the patient over the course of a few days to a week has a good response to the sacral nerve stimulation. If there is a good response, we then internalize the device with a small battery that lasts for about 3 to 5 years and allows for the sacral nerve stimulator to go on working without any interruption during that time. It is important to note that sacral nerve stimulation is not available for everyone and requires the physician or surgeon to do good investigational work before it is offered and implanted. The key to sacral nerve stimulation is when to use the sacral nerve stimulator. Before using the sacral nerve stimulator, a patient must undergo bowel management. A patient must undergo bowel management treatment, and if unsuccessful or partially successful, that is the time where sacral nerve stimulation may be of benefit. Something very exciting is that we have been working very hard to bring sacral nerve stimulation to NMC Royal Hospital. And we are happy to announce that hopefully within the next few months, we will be able to be performing sacral nerve stimulation in children and be the first institution in the Middle East to be offering this therapy.
As a pediatricians, what we need to know when seeing the children with anorectal malformation?
Patients with anorectal malformations are quite complex, just like the malformation itself. When you see a patient with an anorectal malformation, it's very important to understand the anatomy of the malformation because that has prognostic ramifications. When you see a patient with an anorectal malformation, you must think of the VACTERL association. Remember, VACTERL stands for vertebral, anorectal, cardiac, tracheoesophageal fistula, limb, and renal associated malformations. You must evaluate for those malformations to make sure the child does not have one of those associated malformations or issues. So for vertebral, we highly recommend when the child is in the neonatal period, a skeletal survey of the spine to see for any bony deformities. We also highly recommend getting a spinal ultrasound to look for a tethered cord. Typically, before 3 months of age, a spinal ultrasound is able to evaluate for a tethered cord. Over 3 months and certainly over 6 months of age, an MRI would be required to investigate for a tethered cord. Obviously, with the anorectal malformation, it is important to know what type of malformation. Is it connected to the urinary tract? Does it have associated malformations with the gynecology tract in the young girls? Those are important things to know when taking care of a patient with an anorectal malformation. Cardiac. I suggest that in the newborn period, every patient with an anorectal malformation get an echocardiogram. Look for structural abnormalities with the young child's heart, especially if the patient's going to be undergoing anesthesia. It would be great to know if there is a cardiac malformation before the patient gets general anesthesia. Tracheoesophageal fistula. When looking for a patient in the newborn period who has an anorectal malformation, if they are not tolerating their feeds, the next step is to pass a orogastric or nasogastric tube into the esophagus and make sure it passes all the way into the stomach. If you meet resistance, get a chest x-ray to see where the tube is halting, and that will give you your diagnosis of tracheoesophageal fistula if that is present. Renal. Every child with an anorectal malformation should get at least a baseline renal ultrasound. We typically get multiple ultrasounds throughout the child's life just to make sure that the urinary tract is not having any issues. One of the real devastating parts of my job is when I see a patient who is born with an anorectal malformation, the urinary tract is ignored, and later in life there is great scarring of the kidneys. And in fact, I have seen a number of patients with anorectal malformation undergo renal transplantation because of the missed opportunity of treating those problems earlier in life. Limb. That is just a general inspection of the child to see if there are any limb abnormalities. Typically, they are radial anomalies or lower arm anomalies, and if you see that, obviously, X-ray and orthopedic consultation would be required. Patients with anorectal malformations are chronic patients. They have a chronic disease that requires lifelong follow-up. In the newborn period, usually require pelvic reconstruction for their anatomic malformation. But later in life, actually further care and more important care is required. During the infancy and childhood, issues with constipation or fecal incontinence and potty training are important and should be followed by specialists who really know how to care for these patients. If the patients have issues with fecal incontinence or soiling as they get to be school age, we need to make sure they're socially clean and able to participate in activities with their peers and not have any social consequences due to their malformation. As time goes on and they become teenagers and young adults, we need to make sure they're independent. And there are a number of ways we could do that for patients with anorectal malformations. And it is important to have that patient with an anorectal malformation partnered with a team that cares for these patients in a multi-specialty practice. And so patients with anorectal malformations require care for a lifelong period of time, whether it be because of their stooling problems, they need to make sure their urology and urologic tract is cared for. If it's a female, gynecology plays a role in these patients as they could have different anatomic malformations associated with their gynecological tract. And as they approach adulthood, we just need to make sure they're completely independent and can live a really successful, fun life for the future.
Professor, it was our pleasure to have you here at NMC Royal Hospital. Thank you for answering our questions.